And I'd like to say as well, Carolina, that the accredited centre scheme is so good. And as a centre that's gone through that process, we learned so much about managing Duchenne and what we could do to improve our service. So I would really recommend it if people are interested in applying.
Brilliant.
And one of the things that has come out from some of those centre visits, but also from my own service and other colleagues that I speak to around the world, is that transition continues to be um, a difficult area in the management of Duchenne dystrophy, particularly funding for adult services and developing adult services. Um, Today, I'm going to talk about a project that we were involved with recently, which has been published. And firstly, I'd like to make some disclosures that the work I'm going to describe did receive some funding from PTC Bio for a company called Oxford Pharmacogenesis to provide some administrative support. And these are my other disclosures. So, why is it important? Well, transition is the process of becoming an adult. So, we often think of transition as the transfer from pediatric to adult care, but it's not. It's growing up, and the transition period extends from adolescence around the age of 12 up to the age of 25. We know that the frontal lobes of the brain continue to develop in young adults till they're 25 years of age. And so, in order to become an adult, the transition process in healthcare, particularly for our patients, is to mentor those teenagers so that they can develop competent life skills. So teenagers need to learn how to live a healthy lifestyle, how to be involved in shared decision making in their own healthcare, planning their higher education and employment if they're able to, and also learning to manage their finances. And if you're a man with Duchenne, you're going to be an employer. You have to manage and employ a team of carers. And also, growing up through this teenage period is about learning how to develop and maintain relationships. We also know from other areas of transition in healthcare, particularly diabetes, for example, cystic fibrosis, and adolescent cancer, that the behaviors that are learnt and the attitudes that develop during these teenage years will spill over into adulthood. And so if that young person develops some negative attitudes or attitudes that might be negative for their healthcare, that will have negative consequences in the long term. So a good transition is about helping that young person develop these behaviors, and this will result in better outcomes. We also know that adult services for men with Duchenne are generally lacking around the world, and that there are few adult specialists who have experience in this disease area. So I was really pleased to be involved in this international study to develop a consensus guideline for transition using a Delphi approach. And I'll explain what a Delphi approach is in a moment. In case you want to look up the paper, it's open access and it's published in the European Journal of Pediatric Neurology this year. The aim of this study was to establish an international consensus guideline regarding best practices for transitioning adult patients with Duchenne from pediatric to adult care and ensuring that they have continuity of care. And these guidelines have since been endorsed by the European Society of Pediatric Neurology. So, what is a Delphi process? Well, if any of you have taken part in board meetings or just a meeting, you'll know that people who are very extroverted can, if you like, dominate meetings. And so quiet people who are more reflective might not have their point of view represented. So the Delphi process involves various stages, but it includes voting and passing comments anonymously online so that the loudest voice and the quietest voice are equally represented. It also allows people to change their point of view without loss of face. So there is this iterative process which requires a series of voting rounds and modification of statements, allowing people to change their minds. And then finally, an open, transparent round where everyone can analyze the final results and make any final modifications, which is done transparently, again, resulting in a consensus opinion. So it's a very clear, transparent, and fair way of developing a consensus. So this process began with the steering committee who defined the overall aims of the project. So I chaired the steering committee, and as chair, I was a non-voting member of the Delphi process. My colleagues were Thomas Sedgerson and Diana Castro, and between us, we invited an international expert voting round of 15 members from 5 continents and 13 countries. They all had extensive experience in Duchenne, so we included both adult and pediatric specialists in neurology and rehabilitation, respiratory medicine, metabolic bone disease and endocrinology. We also had a patient advocacy group and a patient representative together with a policy advisor for transition and young people. So this was our process. So the roles of the steering committee are here in blue. So we defined the overall aims and scope and the main themes. We reviewed and approved surveys, and we interpreted the results. The expert panel were involved in 2 rounds of anonymous voting and ranking, and 1 round of face-to-face meeting, again, modifying and voting the statements. The Oxford Pharmacogenesis provided admin support by emailing people and also undertaking a systematic literature review to help with us when we came to developing those statements, and then distributing surveys and analysis of results. And this resulted in a published paper. So the methods, as I say, started with the systematic reviews. So altogether, 215 papers were screened. 179 were excluded on the basis that they didn't have enough information. About 36 were assessed and for eligibility, but 26 in the end were felt to be suitable for a qualitative synthesis. And on the basis of these papers, we created some consensus statements, and then these were modified and scored in the 3 voting rounds. And in order to reach consensus, we had to have at least 70% agreement. So we actually identified a number of key topics, and consensus was agreed on 48 statements. I'm going to go through some of those statements, but not all of them because we haven't got a lot of time, but I've selected out a few that I think are interesting. And if we think of the topics, they included transition planning, the transition process, the post-transfer arrangements, communicating with young people and their families, and supporting young people with Duchenne into adult life. So in terms of transition planning, it was agreed that transition planning should be discussed early, but at the very latest by the 15th birthday. All centres should have a designated lead person with appropriate cover when they're unavailable, and their role is to organise and support this transition process. And there should be a formal protocol in place to guide transition and the transfer of care to adult services. It was felt that these transition plans need to be individualized and tailored to the individual medical and social needs of that individual, and that both pediatric and adult consultant neurologists should be responsible for overseeing the plan. Written information should be provided to the patient and their family. But more importantly, the participation of the patient in this process is essential. In terms of the process, so moving from pediatric to adult services, it was felt the young person should meet the adult team before their care is transferred, and that there should be a combined pediatric and adult transition clinic. And for highly complex patients, there should be an interdisciplinary case conference. The health record should follow the patient. But if it's not possible because of local legal issues, then there should be a detailed summary. And the transition process should be completed by 25 years of age, although it can be earlier in some patients if they're more mature. In terms of post-transfer management, it was felt that adults with Duchenne require a minimum standard of multidisciplinary care, and it was noted that this is often not currently available. It was also noted that adult care providers may not be familiar with Duchenne dystrophy. The adult team should include a healthcare worker who has formal training to support the psychological and social needs of the patient, and that there should be support available for palliative care team and symptom control, supporting patients and families, particularly in the end stages of the condition. It was again agreed that adults with Duchenne should be managed in a single specialist centre with access to all of their appointments on the same day. In other words, the cardiology, the respiratory, the neurology on the same day. And that non-specialist centres should have access to a specialist network of healthcare professionals. So this could be done, for example, with telemedicine. In terms of post-transfer management, I think one of the most important issues that was highlighted was that adults with Duchenne should be allowed or enabled to continue steroid treatment. It was noted that a lot of patients are advised to stop steroids. And it was also noted that they should all have an emergency care plan with access to hydrocortisone. It was also agreed that adults with Duchenne should have the opportunity to join clinical trials. This is something that doesn't happen at the moment. When thinking about communication with young people with Duchenne, it was felt that there was a lack of preparation for shared decision making. So this needs to start in adolescence. And it was felt that healthcare professionals should communicate directly with the teenager who has Duchenne in plain language. So starting the preparation for making decisions early. Important topics that need to be explored with young people include sometimes sensitive medical issues. There may be sensitive social issues, treatment escalation plans, and long-term care plans. Healthcare professionals should offer to see the young person alone on their own, and decisions made by a young person who is legally competent should be respected. And then when we think about supporting the young person with transition into adult life, it was felt that mentoring should be led by a qualified healthcare professional together with peer support and advocacy groups. And we've heard this already from Carolina, how important this can be. The young person needs to be mentored in helping them to access healthcare as an adult. They need to learn how to navigate this very complex system. They might wish to think ahead about future living arrangements. Do they want to carry on living at home with family? Do they want to go to university and live away from home? Do they want to live away from home in the longer term? I think giving people goals for education and employment are also important aspects. And that gives people a positive view of the future, and they know where they're going in life. young people also need mentoring on personal relationships and intimacy. They will need mentoring on their personal care, how they want that to look when they're an adult. And also, we need to think about respite care and for people who are unable to make decisions, power of attorney, or other legal processes. And it was noted that a DMD transition toolkit has already been developed. And I put the reference here by Trout in Pediatrics at the bottom of this slide. So just to conclude, really, this is quite a complex document, and I would really urge you to download it and read it. It does make some very specific recommendations. It's the first ever published international consensus guideline for transition. And actually, what it's advocating is a gold standard. We know that not everyone's going to get there quickly, but this is best practice, and it's something that we should all be moving towards within healthcare services. And the aims of this are to improve the planning process, improve the management of adults with Duchenne, improve the communication between healthcare workers and teenagers, and to better support young people and adults with Duchenne dystrophy. And I'd like to say a huge thank you to the many people that were involved in this process, particularly the pharmacogenesis team, who were amazing in pulling it all together and chasing people up and sending emails and producing the voting questionnaires online, but also to the voting members who gave up quite a lot of their time for this process. So Thomas Sedgerson, Diana Castro, Luca Bello, Filippo Bucella, Anita Cairns, George Carranzo del Rio, Imelda de Groot, Lauren Elman, Isabel Inzani, Andrea Klein, Oscar Mayer, Håkan Miller, Alessandra Onofrio, Alexandra Prufa de Queiroz, Campos Arrojo, Ulrika Schara Schmidt, Carsten van der Wingart, Leanne Ward, and Joe Wilmshurst. And I will stop there, and hopefully we will have some time for questions as well. So I'll stop sharing my slides.